All right, great. Sorry, we had a mild technical challenge with Dr. Knife's computer restarting during her talk. But our next talk is by Dr. Hallowell, the director of the ILD program here at MGH, who is going to talk about the treatment challenges in sarcoid. Dr. Hallowell?
Thank you. Dr. Knight, Rachel is always a tough act to follow, and I'm glad we got all the technical difficulties out of the way with somebody smarter than me, because I probably would have panicked and still be offline. So, Rachel, thank you for taking one for the team there. It's a real pleasure to be here. Thank you for the invite. And for those who are returning, welcome back. These are my disclosures. I have some industry ties. I don't think any of them are going to be relevant to today, but if you find that's the case, please let me know. So our objectives today, for the brief time we get to share together, recognizing the indications to treat pulmonary sarcoidosis, understand the therapies used in the treatment, looking at the data behind that. Spoiler alert, it's actually pretty scant, which is disappointing. So you'll see we need more studies. And then become familiar with some of the common pitfalls encountered in the treatment. And my goal here today is not to necessarily lecture at you and tell you a bunch of stuff you don't know, but this is more maybe a chance for us to commiserate together virtually over some shared issues we've had together in the community. So I'll start just with a brief vignette here. A 45-year-old woman coming in with chest pain, dry cough for 3 months. And as many of you may experience, chest pain and chest discomfort is a very common phenomenon in our patients, sarcoid chest pain. And we don't know why this happens or necessarily how to treat it. And it doesn't necessarily portend anything specific with the prognosis, but it's just an interesting finding that you'll see. She was sent to urgent care for a chest x-ray, which was read as a left-sided pneumonia, which didn't improve following a course of levofloxacin, and then had this CAT scan showing the nodularity that you can see here. She had a transbronchial biopsy showing numerous non-caseating granulomas, just therefore confirming what was thought to be sarcoidosis. And so the first question is, does this patient require therapy? The idea being first, do no harm. I think that's been drilled into all of our heads. And how aggressively would you approach this case? How aggressively would you treat this patient, if at all? Can we do more harm than good? And how good is this data supporting the standard of care that we impose upon our patients? This is just a refresher for the stages of sarcoidosis. I need to refresh myself and remind myself of these not infrequently, but stage 1 is just when you have adenopathy. Stage 2 is when you have adenopathy and then you get the infiltrates in the parenchyma. Stage 3 is infiltrates alone. So the adenopathy goes away and then you're just left with the infiltrates. And then stage 4 is fibrotic disease. And it's important to remember that this is from old studies when we were using x-rays alone, not CAT scans. And so CAT scans are a lot more sensitive and probably going to bring in a lot more of the stage 2 and stage 3 disease. Patients will come to you wanting to know what their stage of sarcoidosis is, as if it's a cancer. And it's not as relevant for sarcoidosis, except in that it does sometimes prognosticate the rate of spontaneous remission. And you can see here that unless you're getting into stage 3 and 4 sarcoidosis, there is a pretty high rate of spontaneous remission, or at least stability. And once you do have spontaneous remission, it's actually very unlikely that the sarcoidosis is going to come back, or at least come back with a vengeance. And so stability is a good thing with sarcoidosis. But what are the indications to treat? When do we really sort of bite the bullet and say we're going to consider putting patients on something that's going to be potentially quite toxic? So some of these are quite obvious, right? Severe respiratory symptoms, things that are really impacting your patient's quality of life, declining serial PFTs over 3 to 6 months, so that you're getting the sense that the trajectory here is concerning. Progression of radiographic abnormalities. So you're repeating a CAT scan and then the next one looks a little worse and then the one after that looks a little worse still. And you're really just kind of getting the sense that this probably isn't going to go well radiographically and you're starting to worry about more inflammation leading to fibrosis. Hypercalcemia has to be addressed. Severe constitutional symptoms, again, profound fatigue, profound aches, severe muscle disease, things that really impede a patient's ability to live the way they want to live. And then you have the organs that really just can't be ignored. Now, we all know the lungs are the most important organ in the body. That's our bias here, but not in the case of sarcoidosis. So, eyes, significant neurosarcoid, cardiac involvement, usually, and kidney involvement. These are organs that, when we see involvement here, we pretty much always need to treat. Today's lecture is going to focus primarily on pulmonary sarcoid, though. There are some risk factors for a worse prognosis or a lower chance of spontaneous remission. These include certain races, age, symptom duration, the number of organ systems involved, and the presence of splenomegaly. Now, what's interesting is that Lofgren syndrome, and if you remember from your boards, this is your triad of hyaluradenopathy, erythema nodosum, and polyarthritis, almost always resolve spontaneously. So even though these patients feel really ill when they first present, it sort of burns out, right? So this is like putting paper in the fireplace. You get a big sort of burst of energy and they come in hot, but then it sort of fizzles out on its own. So that's actually a good prognosis despite patients looking quite ill at the onset. So what about treatment? Now, if you look at the size of these studies, just as we kind of go through this, and you look at the dates from these studies, you're going to find that industry has not really invested much in sarcoidosis, and that's a little bit disappointing. In part because they didn't think there's going to be a good return on their investment, and so people just haven't been putting money into research and development here. So this is a study that goes back to 1996. This was the grunge era. Pearl Jam was releasing some of its best music. I was much younger. And so here, this is an interesting study. And they started with 183 patients. And there's a time entry point of -6 months. And the reason for this is sort of what I mentioned previously, that a lot of sarcoidosis is going to resolve spontaneously. And so they wanted to give a run-in period of 6 months to kind of see what was going to happen with these patients, because you don't want to randomize patients to treatment if it's just going to get better on its own. So after 6 months, they said, okay, we have 183 patients. They all had stage 2 or 3 disease. Let's see how things settle out. And then what are we left over with? And then randomize at that point. So here already you can see that after 6 months, you have 58 of those patients already have improvement. And so they become group O for observation. Nothing to do. We're just going to kind of watch. 33 of those patients had worsening or a deterioration, and so they become group P or prednisone. But then you have 58 kind of in the middle, where they didn't have symptoms, but their x-ray didn't get better spontaneously. They just kind of like, stayed in the middle. And so what do you do there, right? This is to treat or not to treat. That is the question. And so those are the patients that were randomized. 27 randomized to group L to receive treatment, 31 S selective. And so the L group, they were given treatment to maintain max radiographic clearance. So let's make the imaging look as pretty as possible. But the selective group only got treatment with steroids if their symptoms got worse or their imaging got worse. So a lot more conservative. And so there were, in the end, 27 patients in each group. And so what happened? So again, it's not a very big study, but it's kind of the best steroid study we have in terms of the design and randomization. And what you can see here is that the group that had slightly more aggressive steroid therapy, just kind of treat to make things look nice, at the end of the treatment period, they did have a higher FEV1, 95.9 versus 86.9, and that was statistically significant. They also had a higher vital capacity, 99 and change versus 90 and change. If you look at the amount of steroids received, in the end, number receiving steroids, 25 versus 6. The mean dose in overall milligrams was higher, as you would expect. The mean daily dose per user was slightly higher, but at final assessment, it was pretty much a wash as to who was still on steroids. And when you look at the side effects, most of it was related to weight gain and Cushingoid features, all the weight gain was pretty much in the first 12 months, 3 kilograms versus 1 kilogram. But at the end of the study, that kind of evened out and was non-significant. And so it comes down to weighing the risks and benefits of treatment. We know the risks of prednisone. I don't have to go over these with you. You probably know this better than I do. When we talk about other agents such as methotrexate, infection, need for blood draws, malignancy, liver toxicity, but how much can we really improve symptoms? How clinically significant are those changes in PFTs if things are going to stabilize anyway? What is the slow progression going to be, and how long is it going to continue to progress? In terms of quality of life, certainly none of these studies show mortality signals. I don't actually have an answer for that. That's one for you to ponder throughout this week. Prednisone is first-line therapy, and part of the reason is that it works rapidly, it's inexpensive, everybody's familiar with prednisone. There's no real science behind these numbers, but in general, we tend to use 20 to 40 milligrams. We taper after 4 to 6 weeks, and the goal is to get down to 10 to 15 milligrams max by month 4. And this is to minimize side effects. And because based on our experience, most patients should not need more than that if you're treating something like pure sarcoidosis. And so this little schematic that I sort of put together here sort of shows what a patient's dose may or may not look like, right? So you start at 40, 30, 20, 15, 12 and a half, and then we kind of lag at 10 for a bit, and then we chip away to 7.5, try to go to 5, etc. Everybody's happy. But that's not necessarily what happens. And so we'll come back to another slide in a second here after I show you this case. So this is a 50-year-old woman with persistent symptoms, minimal radiographic improvement despite 2 months of prednisone. And so she had been on 40 milligrams daily. She didn't feel any better. You can see pretty extensive disease here in this peribronchovascular distribution. It's upper middle lobe predominant. And so in reality, what we see more often than not in some of these more significant or refractory cases is perhaps something like this. So we start at 40, we try to come down, they feel a little worse, we go back up to 20, we try to come down, they feel worse, and we decide, well, maybe the prednisone isn't working, or if it does work, every time we try to come down, they flare again. I use flare lightly here, but they just tend not to feel as well. And so we feel inclined to use a steroid-sparing agent. And so we would interject somewhere in this range with something like methotrexate. We'll talk about the choice of steroid-sparing agents here. And then again, slowly try to bring the prednisone dose down and see how patients tolerate that. If we're going to see this response to steroids, it's typically seen by week 3 to 4. And the relapse rate can vary anywhere from 14 to 74%, depending on the series. And as you might imagine, the relapse rate is higher in patients with a chronic course versus acute sarcoidosis. So the longer the condition has been there, the more baked in the inflammation is, or the more fibrotic of a component, the less likely you are to have a treatment response or an enduring treatment response. If you're going to see a relapse, it tends to happen early and within 6 months of stopping therapy. And once you get remission, you're more likely to maintain remission. So success begets success. So what are the indications for using something a little more advanced than steroids? Well, certainly if disease is progressing despite using moderate doses of prednisone, we all know what prednisone can do to bones and sugar and weight gain and sometimes marriage when people become grumpy on high doses of prednisone. The inability to wean below 15 milligrams after several months. And this is an arbitrary number, but I do think we underestimate the toxicity of chronic prednisone use, even at moderate doses, not just the infection risk, but really the impact it can have on bone health. And then there are some patients who just can't tolerate it or flat out refuse it because of previous experience or because of what they heard anecdotally from their friends who have COPD or asthma or other rheumatologic conditions. And so there are patients where I will have a very, very low threshold to use a steroid-sparing agent or sometimes forego it altogether if I can. And these are patients with known osteoporosis, brittle diabetes, previous reports of psychosis on steroids. So it's really a case-by-case basis, and it's important to talk to your patients up front about steroids, what they know about steroids, what they've heard about them, and make sure that you have a frank conversation about them reaching out to you if they start experiencing side effects, because they may not feel empowered to tell you just how poorly they feel when they take these. In terms of the steroid-sparing agents that we frequently think about, most of us have used methotrexate or have thought of using methotrexate for sarcoidosis. But azathioprine, leflunomide, mycophenolate, and others have been used as well. And this is just a non-exhaustive list of some of the side effects that we think about. And one thing I'll say here is, and I'll show you a little bit of this, there is no data really supporting one agent over another. Most of these agents work roughly 60% of the time. And it's hard to predict which one is going to work for any particular patient. And unlike some of the other connective tissue diseases and the treatment approaches there, and we have really nice lectures talking about that, sarcoidosis is a bit different in that we're more likely to stop one agent and interchange with another, because just because one doesn't work doesn't mean another won't. As opposed to your patient with myositis ILD, where if mycophenolate doesn't work, there's a good chance azathioprine won't either. That's not necessarily the case with sarcoidosis. And why that difference, I'm not sure. There's something different about the immune system in sarcoidosis, but we do try to exchange rather than add on in sarcoidosis, more so than we do with other connective tissue disease ILDs, or processes, I should say. So why methotrexate? Why is this first-line therapy for sarcoidosis? What is the evidence here? The heaps and heaps and heaps of evidence for methotrexate. Well, there actually isn't much. It's shockingly scant. Well, we use methotrexate in part because it's the only agent tested in a randomized placebo-controlled trial. Let me repeat that. Methotrexate is the only agent tested in a randomized placebo-controlled trial for sarcoidosis. That is amazing to me. And that was back in 2000. New onset symptomatic sarcoidosis within 4 weeks of starting prednisone was the major inclusion. Patients were randomized to receive methotrexate versus placebo, right? So this is just, is any steroid-sparing agent better than placebo? Right? So we're not comparing steroid-sparing agents one against another. And prednisone was tapered monthly per a predetermined schedule. And a whopping 24 patients were enrolled. 15 received at least 6 months of methotrexate, 8 received placebo and prednisone. And here's the data. So if you look at, some of this is a little fuzzy, this is essentially over a year, so 12 months of therapy. We're looking at daily prednisone dose, and you can see that methotrexate is a steroid-sparing agent, so it's effective at steroid sparing. And there is a lower daily prednisone dose at the end of the study, and at 6 months in patients on methotrexate versus placebo. And so because of this, this study by one of the most prominent sarcoidosis experts, methotrexate became the agent of choice, and with familiarity comes momentum, and this is what we've used. There is a retrospective cohort study looking at methotrexate versus azathioprine, and this study was much bigger than that small randomized study. And you can see here 145 patients receiving methotrexate, 55 receiving azathioprine, and they tracked patients for 2 years. And as best we could see with this retrospective design, prednisone use at years 1 and 2 was not significantly different between the two agents, but they were both effective as steroid-sparing agents. The only difference was that azathioprine seemed to be associated with a higher rate of infection and a trend towards a higher discontinuation due to adverse events or side effects. Well, what about other things that have been tried, at least in the realm of scant data here? So people have looked at chloroquine therapy, patients with stage 2 or 3 disease. 23 patients received a 6-month run-in period, and then 18 were then randomized to either maintenance or drug-free observation. And of those, 10 received hydroxychloroquine, 8 received nothing. So this was a sort of pseudo randomization of the continuation phase. And here you can see that patients in the open label phase in the beginning did have improvement in their dyspnea, cough, voice was non-significant. Keep in mind, though, that a lot of patients with sarcoidosis will spontaneously improve. So it's hard to know if this was actually related to the treatment or if this was going to happen on its own. However, if you look at the randomized portion, those small numbers of patients who either continued on chloroquine or were then put on control going forward, it appeared as if the FEV1 slope and the FVC slope declined more slowly in the chloroquine group compared to controls, although in the FVC that was just a trend. So I wouldn't say this is convincing data. I think it's maybe hypothesis generating that potentially this agent could be considered for further trials. What about infliximab? So certainly it's become standard of care to use infliximab, which is anti-TNF therapy, in patients who have refractory sarcoidosis that doesn't respond to consistent use of steroids and methotrexate or some other steroid-sparing agents. What is the evidence for that? So this comes from primarily this study showing 138 patients in the US and Europe who were on at least 10 milligrams of prednisone or at least one immunosuppressant for 3 months. It's a double-blind placebo-controlled trial randomized in this fashion, 1:1:1 placebo, or one of 2 doses of infliximab that were weight-based. And the primary endpoint was FVC. And so here you can see the primary data going out to 52 weeks. This is the placebo here along the bottom in these circles. Here, the black squares is the higher dose of infliximab, interestingly, and here is actually the lower dose. And so based on this study, infliximab is used as essentially standard of care for refractory sarcoidosis. The biggest risk with infliximab, not surprising, and we've known this based on our patients who are being treated in the GI world with inflammatory bowel disease, is a slightly increased risk of infection. And in open label studies, we can see here patients who have chronic refractory disease, despite the use of other significant therapies, and pretty refractory disease because they've been requiring several other concomitant medications and steroid-sparing agents, that even in those patients who have pretty refractory disease, you can see the scatter plots here showing that the majority of those patients do have an improvement in FVC, an improvement in FEV1, and an improvement in DLCO. And despite having what was considered to be refractory or severe disease, you can see the trend in FVC for those patients. It was going down, and then after the initiation of infliximab, it improved. So infliximab does seem to be helpful in patients who have significant disease. And this is just a little schematic here showing you patients in these studies who were getting PET scans as a way of monitoring disease. And we don't routinely get PET scans in all of our patients to monitor disease activity. But here, this is SUV max on the y-axis, start and 6 months after therapy with infliximab. And what you can see here is that most patients, with the exception being 1, 2, 3 patients who had a slight increase, all patients had either stability, with a majority of them having decrease in overall SUV uptake throughout. And then this schematic on the right shows you sort of a representative view of patients who had significant activity here in the lungs, which improved following infliximab. So this is something that came out recently in CHEST, which is essentially just a retrospective analysis of patients with sarcoidosis over the past several years using a claims database. So there are issues with doing research using claims database, but sometimes it's the best we have. And I think these authors did a pretty good job. And this shows current treatment patterns. And so, again, we're focusing on pulmonary today, but if you look at, in general, what providers are using to treat sarcoidosis, you can see that the vast majority, 89%, are getting steroids, 23% are getting methotrexate, and then there's a smattering of other things in here. So 5% got mycophenolate, 8.7% got hydroxychloroquine, which I found kind of interesting that it's actually number 2 on this list, behind methotrexate, and then some infliximab, adalimumab, a little bit of azathioprine, etc. So what about antifibrotics? We know that sarcoidosis can progress to a fibrotic phenotype, especially if left untreated. Sometimes despite treatment, these patients go on to have severe fibrosis. There have been studies and abstracts showing that in patients who have ongoing severe progressive disease, despite steroid-sparing agents, if you do repeat biopsies in them, they have ongoing inflammation, ongoing granulomatous disease. So the granulomas are still there and active. So there seems to be inflammation embedded that drives the fibrosis. We're all familiar with nintedanib, the antifibrotic, which is approved not only for IPF, but for progressive fibrosing interstitial lung disease. And there are studies showing that this is potentially useful in other interstitial lung diseases, including sarcoidosis. And so in these studies, sarcoidosis was represented, and we think these antifibrotic agents are potentially useful in sarcoidosis. Treatment algorithms for refractory disease. This was lifted from an old paper, but it's not necessarily outdated because I don't think much has changed here. But essentially, most of the time, we're starting with glucocorticoids. And if there's disease progression, it kicks you into this green box here. We're giving a 6-month trial of a steroid-sparing agent. And unfortunately, these steroid-sparing agents all take about 6 months or so to really kick in and show their full effects. If there is still disease progression, as I had mentioned, we'll change the antimetabolite, will change from methotrexate to azathioprine to mycophenolate, etc. Or consider adding on infliximab if the disease is progressing too rapidly or seems to be life-threatening. And then I don't get into it in much detail here, but there is some evidence that if disease continues to progress, that potentially this is due to underlying organisms. And so using antibiotic regimen under the CLEAR protocol to treat non-mycobacteria, or non-tuberculous mycobacteria, I should say. And always throughout this process, the goal should be to taper glucocorticoids to the lowest tolerable dose. All right, so now a couple pearls, just some things to keep in mind as we're treating these patients. So the third case, 52-year-old woman, initially progressive stage 2 pulmonary sarcoid, has a history of anxiety. Sarcoidosis is 2 years previously diagnosed, and she's on 5 milligrams of prednisone. Initially was on 20, that had been tapered down, and she's on methotrexate 20 milligrams weekly and had been on that dose for 9 months. She takes folic acid and a multivitamin. She's a very active woman. She works as a spin instructor, teaches multiple classes a day, incredibly fit. She doesn't smoke or drink or use any illicit substances. And we monitor blood work in our patients. And as you can see here, this is her hematocrit trend. And everything was fine until September, when she had a new anemia down to 27.4, and then repeat within a few weeks, she was still at 27. We all know methotrexate is hepatotoxic, but I always check a basic metabolic panel in these patients as well. And this is her creatinine trend during this period. So she had a bump in her creatinine, which was also sustained. Her UA was bland, and her LFTs were normal. And so the first question is, well, what's happening, right? What's going on? What are the next steps? And the first question is, well, is this worsening sarcoid? Is this sarcoidosis affecting her hemoglobin? Is this bone marrow infiltration from sarcoidosis? Is this renal sarcoid? Is this hypercalcemia with kidney stones? Does she need more immunosuppression? So do we need to double down on her immunosuppression? Does she need to be pulsed with steroids? Or is this drug toxicity? Methotrexate is not typically nephrotoxic. So does that explain what's going on with the kidneys? How can we kind of tie all this together? Or maybe there's two different things going on. So what is the real story? So sarcoidosis can affect many things, and the temptation is always there to give more immunosuppression. But when you're dealing with something like methotrexate, and because methotrexate is still considered first-line therapy for sarcoidosis until further studies, when in doubt, you have to stop the methotrexate. And so it turns out that she was taking a new high-protein supplement for muscle enhancement with high levels of keto acids. She had changed her schedule and was taking consecutive spin classes. She wasn't hydrating well. She was trying to train her body to work out with just one bottle of water throughout multiple sessions. And she thought this was a good way of getting into a different kind of shape where she wouldn't need as much water. So she was essentially putting herself into renal failure. She was referred to nephrology anyway. She had a negative workup, normal renal ultrasound, urine electrolytes, et cetera. And when she stopped the supplement and started drinking normally, her renal function normalized completely. And she was able to be reintroduced to methotrexate without an issue. Now, this is important because even though methotrexate is not nephrotoxic, it's excreted primarily in the urine. And so you can see here that you need to dose adjust your methotrexate for patients who have CKD. And I typically will avoid using methotrexate in my patients who have chronic kidney disease. And you can get into a lot of trouble very, very quickly in patients who have changing renal function on methotrexate. And it doesn't take a lot for this metabolite to accumulate very rapidly and cause severe marrow failure, sometimes irreversible. And we've had patients die here because of low-dose methotrexate prescribed for ocular reasons and whatnot, because providers didn't know that they had renal failure. So you have to be really, really careful. Case 4. So this is a 43-year-old man coming in with chest pain. So there again is this chest discomfort, intermittent palpitations, and near syncope. He was found to have runs of VTAC, and PET imaging was consistent with cardiac sarcoid. He received an ICD and was initiated on a slow prednisone taper starting at 40 milligrams daily. And so here you can see January to August, and despite being on a prednisone taper, you can see things are actually worsening. And the point I want to make here is that sarcoidosis can affect different organs at different times, despite active treatment. And so the lungs and the heart and the kidneys and the nerves and the skin, they're not in sync. And so you can have complete resolution of your pulmonary sarcoidosis and the lungs are clear as a bell, but the heart can become active and you can have progressive cardiac sarcoid. Or you can have cardiac sarcoid that's clearing and the heart is doing fine, but progression in the lungs. And so you can't monitor one organ symptom and use that as a surrogate for another. And we see this in many other connective tissue diseases where the joints are improving and the skin disease is improving in patients with myositis or antisynthetase syndrome or their connective tissue disease, but the lungs are getting worse and their ILD is progressing and the fibrosis is progressing. And so we really have to pay attention to every organ system separately on schedule, continue to do eye exams, continue to check the kidneys, continue to check the liver, et cetera, because they all march to the beat of their own drummer. So here's another case, 47-year-old woman on infliximab for refractory disease and low-dose prednisone. Previous methotrexate was ineffective. Her CT imaging originally cleared with minimal adenopathy, and now she's coming in with 5 weeks of shortness of breath, cough, and chest pain. And so here you can see there's new disease in the chest, typical pattern and distribution for sarcoidosis, and she's on infliximab and low-dose prednisone. And so here, the question is, well, why would this happen? And if you look, when we checked her infliximab level, which was something I learned many years ago from our GI colleagues, because they use a lot more infliximab even than we do, her infliximab was low at 0.8. And you may say, well, why would you check an infliximab level? Well, there's actually a target trough that you would expect to see. And we don't necessarily care about the trough so much as we're using this in our case as a screen for infliximab antibodies or antibodies against infliximab, which these patients can form. And so if they start forming antibodies against infliximab, it renders it less effective. And so this patient had developed anti-infliximab antibodies. And we'll often keep patients on low-dose prednisone or even low-dose methotrexate, even though the methotrexate wasn't fully effective, to reduce the risk of forming antibodies against the infliximab. And so you have to consider antibody formation in patients if they start failing infliximab therapy, even after it was useful for years. And so if your trough level is undetectable, think about this. The other reason it's important is not just because it makes it less effective, but because all patients in at least one of these series developed an allergic reaction within 1 year if they had antibodies to infliximab. So it's a harbinger of a possible severe, sometimes anaphylactic reaction. And so you want to know about it and consider switching therapy. Interestingly, in that series, those patients were on some dose of prednisone or methotrexate, and so it wasn't necessarily protective for them. And so here, I'm going to end with a bit of hope, because hope springs eternal. I talked about our lack of clinical trials and studies, and how nobody was really interested in investing in poor sarcoidosis. But finally, there is this new agent, efzofitimod, which selectively modulates neuropilin-2. And as you all know, actually, I didn't know this, but as I'm sure somebody on this call knows or knew before, neuropilin-2 downregulates the innate and adaptive immune responses. And so maybe it has these anti-inflammatory or anti-autoimmune effects. And so because of this new medication, which we were part of a trial here with our own Dr. Gibbons, who's one of our local sarcoidosis experts, we all learned a little bit more about this pathway and this agent, which phase 3 studies are wrapping up. I'll show you some phase 2 data in a second. And so the idea is that maybe we can tamper down the autoimmune response with this agent here. The phase 2 data was maybe promising, and the hope is that it can have impacts on stabilizing or even improving FVC in patients with active sarcoidosis. This was a 24-week study. That it's hopefully helpful as a steroid-sparing agent, less side effects than prednisone, more infection risk than methotrexate, et cetera. But as we've learned, phase 2 trials can be incredibly misleading. So we wait with bated breath on the phase 3 results. It's now locked out. We just have to wait for the results to come to us. So in summary, not all patients with sarcoidosis require treatment. And I think one of the biggest challenges is deciding when to treat, when to sort of pull the trigger on that. Prednisone remains first-line therapy for responsive disease. There's no good data comparing the various steroid-sparing agents. And so if they don't want to take methotrexate, or they don't do well with methotrexate, et cetera, don't feel bad about trying another steroid-sparing agent. And each treatment modality presents unique caveats and treatment challenges. So with that, I will end, and I thank you for your attention.